name is Dr. Karp. I'm a radiation oncologist. I am the founder and director of the Rahway Regional Cancer Center. Radiation oncologists are doctors who specialize in cancer and use radiation therapy to treat cancer. There's a new trend in the field of radiation therapy, and it's called hypofractionation. It can also be referred to as accelerated fractionation. When radiation therapy is being delivered to treat cancer, it's given in courses, generally 5 days a week over a period of several weeks. Typical radiation therapy treatment courses will last anywhere from 5 to 9 weeks. And we typically fractionate it into small doses on a daily basis. What we're doing here when we're delivering radiation is we're literally depositing energy into the tumor. So by doing it at a low daily dose, it's much safer for normal tissues that surround the cancer. It's much more effective. There's much less chance for causing damage to normal tissues. Hypofractionation is a technique where you give the radiation therapy treatment course using less fractions or less treatments. And you could do moderate hypofractionation where, say, a 9-week course of radiation therapy turns into a 5-week course of radiation, or you could even do extreme hypofractionation or accelerated fractionation where people give as few as 5 and even 1 dose of radiation for the entire treatment course. The problem with doing it that way is that in order to give fewer doses, to compensate for the fact that you're giving less doses, you have to increase substantially the actual radiation therapy treatment dose per fraction. And there's a very basic tenet in radiation oncology. The bigger the dose of radiation per fraction size, the greater is the risk of damaging normal tissues. And by the way, it doesn't even equate with getting better treatment results by doing it that way. So it is neither more effective nor is it nearly as safe as doing it with a standard fractionation technique where you're giving a low daily dose. If you ask, well, why would anyone do it that way? Why would they give the treatment in fewer fractions if this is a dangerous approach? And the reason why is because it's financially motivated. Our field is being pushed very hard by administrators in hospitals and by insurance companies to save money. And unfortunately, the people in our field have been willing participants in this process. Many of the people that are getting trained in the field, they don't even know any better. They're only trained in using these dangerous techniques. They don't understand the risks associated with them because for them, causing serious tissue damage is normal because they don't have the experience treating people with standard fractionation techniques where you're giving smaller daily doses. I mean, if you went to the doctor and let's say you're told to take penicillin 4 times a day for 2 weeks, what would you think if the doctor told you, you know what, you could take everything in that bottle, just swallow it up, and do it in 1 day? I think logic would dictate that that's a very dangerous thing to do. And it might sound trite, but that's actually no different than what's going on in the field of radiation oncology. You've got people that are accelerating these treatments, giving these massive doses of radiation, and it's very, very dangerous. It's very injurious. You can seriously damage and do seriously damage normal tissue. I've seen people who have received treatment and the normal tissue damage has been incomprehensible to me. It's not even just a trend. This is what's being done. We're actually literally being forced by insurance companies to do this to save money, but people in the field are actually doing it preferentially because many of the people that are being trained, especially nowadays, they don't know any better, they don't know any different. You go into the major institutions, the big professor doesn't even see the patients most of the time. They're seen by residents, doctors in training. They carry out these treatments. We learned the importance of fractionating the treatment, splitting it up into smaller and smaller doses. When we split it into smaller doses, it was much better tolerated, less side effects during the actual course of treatment, and much less permanent effects on the normal tissue, much less degree of normal tissue effect, much less degree of normal tissue damage. That when you lowered that daily dose and titrated it accordingly for the total dose, in other words, you can go to a higher total dose, but by giving it at a lower daily dose, that the treatment was much better tolerated, that you got much better cure rates, and that you had a much, much lower rate of normal tissue injury. So for example, the man's prostate sits literally sandwiched right between the bladder, which sits sits right to the front and above the prostate, and the rectum, which sits right behind the prostate. You want to give a very high dose of radiation to the prostate. You want to give as little radiation as possible to the rectum and the bladder. Now, at the same time, part of the prostate is actually interfacing with the rectum and the bladder. So it's impossible to entirely avoid giving dose to the very front wall of the rectum because it's meeting the prostate, or the very back wall of the bladder since it's meeting the prostate. And that's why it's so important that you do the treatment with a low daily fraction size, because if you try to rush it, if you try to do it using a large fraction size and do it with fewer treatments, the normal tissues don't tolerate that well. They are unable to heal as you're giving the treatment. It's very dangerous to use large fraction sizes treating into the abdomen where there are a lot of very, very sensitive structures. You've got small intestine, you've got kidneys, you've got liver, you've got stomach, you've even got heart sitting just above that field. And by using these big fraction sizes, you can injure the patients. And I always think back to my mentor at Sloan Kettering named Steve Leibel. I haven't met a better radiation oncologist in my entire life. And I was fortunate enough to spend a lot of time during my residency, during my training, working directly with Steve Leibel. And I remember one day we were treating a patient who had pancreatic cancer, and it was a big radiation treatment field. There's a lot of small intestine in that field that's somewhat unavoidable. There's stomach, there's liver. And we were using standard fractionation because the patient was also getting chemotherapy at the same time as the radiation. And the chemotherapy is given to elevate the effectiveness of the radiation, but it also elevates the side effects from the radiation therapy when you're doing the two treatments together. We call that combined modality therapy. And we were giving the patient 180 rads per day. When I talk about low dose or standard fractionation, that's what we're talking about. And I remember this particular patient was having a lot of trouble tolerating the treatment. A lot of gastrointestinal distress, cramps, nausea. And Steve said to me, he said, you know what we're going to do? We're going to drop that dose down. We're going to drop it down from 180 to 170. And he said to me, Eric, watch what happens now. Watch how well this patient does. Everybody's different in this world. People are different. They react to treatments differently. He said there's no rule book that says there's something that magical about 180 versus another dose that's close to that. So he said, we're going to drop that down to 170 and watch how well this patient does. Anytime you see that a patient's having a hard time tolerating your treatment, he said, just drop that daily dose down and you'll see, like magic, they'll tolerate it a lot better. So we dropped him just from 180 to 170, and the guy did great. He tolerated the treatment fine. We got him through the treatment as prescribed with no difficulty. It made all the difference in the world. If I had that same patient and I said to the insurance company, because the insurance company tells you how many treatments they're willing to pay you for, well, what's your treatment regimen going to be? Well, it's kind of a big field and there's a lot of small bowel in the field, so I was going to do 170 rads per day to 4,500 plus rads. They would not even think of giving me that many treatments because that's what they do. They give you treatments. They wouldn't pay for it. I can guarantee it right now. They don't want to pay for anything, but the doctor that comes on and does the pre-authorization for the treatment, they don't even understand the concept of dropping the daily dose. They think it's okay to go give that same guy 250 rads a day into his abdomen, blow his small intestine up. Somehow that's acceptable and it's okay. But if you're trying to finesse the treatment and do it right and do it in a way that it's tolerable, they don't want to pay for that. So where did the impetus originally come from? Increase the fraction size, shorten the treatment duration. Where'd it come from? Well, Canada. It has to do with a couple of things. It has to do, first off, with geography. Canada is a gigantic country. If you look at a map, you'll see the area of Canada is actually quite a bit larger than the United States. They thought, gee, you know, it's pretty tough to come for radiation treatments. There aren't that many centers. They're scattered all over the country. People have to travel great distances to get to these radiation centers, and they have to travel oftentimes in harsh conditions. So they started experimenting with giving the treatments over a shorter duration of time. Where you first started to really see this was in management of breast cancer, shortening the duration of breast cancer treatments for women who've undergone lumpectomy, removal just of the tumor of the breast. They need postoperative radiation therapy to the intact breast. The purpose of that radiation therapy is to prevent the cancer from coming back in the patient's breast and to preserve the breast. And a standard technique in the United States for decades has been 180 rads a day times 28 fractions directed to the breast. And I've been doing this now for 30+ years. I have tremendous results with this. We get beautiful cosmetic results, and with our superb technique, we get outstanding control rates. But the point being is, it would absolutely make no sense to try to change that because the results are so good. Why would you even attempt to change something that's giving such superb results? Canada is where they started accelerating the breast cancer treatments. They started using accelerated radiation therapy, moderate hypofractionation techniques to treat breast cancer. Hey, we don't have to give 28 treatments. We don't even have to give 25. We can do this in 16 treatments. So instead of giving 180 rads per day times 28, we're going to give 267 rads per day for 16 treatments. Why don't we try that out and see how it works? When you give radiation therapy, again, you're depositing energy into a volume of tissue. And you strive, or at least should strive, to achieve the greatest degree possible of homogeneity. What I mean is, you want the dose to be as consistent as possible throughout that entire volume. You don't want areas where the tissue is underdosed, but at the same time, you don't want areas that are overdosed. All you have to do is turn your TV set on and you'll hear about institutions now doing 5 fractions, fast 5. If you ever hear the word fast and cancer put together in the same sentence, turn in the other direction and run away. If you come see me at Rahway Regional Cancer Center, we're going to use standard fractionation. And when I say that, we're going to do that whether they pay me for it or not.